So there's a saying in surgery that a good surgeon knows how to operate, the better surgeon knows when to operate, but the best surgeon knows when not to operate. Now, if you or I need a surgeon, we want somebody who knows how, who knows when, and importantly, who knows when not to operate. You see, the tension is that we love operating. That's why we became surgeons. I spent all day yesterday operating, and I loved it. We are the seamstresses, the machinists, the menders of the medical world. We love to cut and craft and create and reshape and reform things. But we're also the decision makers. And making decisions not to operate can be extremely difficult. It's about weighing up the risks and the benefits. You see, because surgery causes immediate harm. And the first rule in medicine is not to cause any harm. It causes pain, there's physiological insult, immediate removal of certain aspects of quality of life, and occasionally it has very serious consequences and complications that tragically occasionally result in death. Now, those risks may well be worth taking if the surgery really deals with the underlying problem, and sometimes it does, but there are many times when surgery doesn't necessarily deal with the problem completely, and it doesn't necessarily guarantee success. And then it's really about weighing up those pros and cons from the individual's point of view. Now, historically, we made those decisions. We single-handedly made decisions and advised patients. Sometimes we nowadays discuss it in a team. But of course, that decision should involve the patient. And the NHS really supports this. It has a mantra which says, "No decision about me without me." And so those discussions between surgeons and patients are critical. Now, what's really interesting is that although they're critical, they're not often studied, they're not audited, they're not scrutinized in any way. And they're really not often the focus of much research. Unlike the massive attention that's paid to what goes on in the operating theatre, what goes on in the consultation, the far less glamorous consultation between the surgeon and the patient, is largely unknown. And so what we've done is we've studied those consultations simply by tape recording clinic appointments. And what we found is that we're very consistent. What we do, me and my colleagues and surgeons across the country, is we consistently talk in detail, great detail, about the technicalities of surgery, what we'll remove, how we'll reconstruct things, and then we go on, usually in a long list, for some time about the technical things that can go wrong. What you'll be surprised to hear is that we're not very good at talking about the long-term consequences of surgery, how it will impact on patients' quality of life, whether it will really deal with the underlying problem. And we've also interviewed patients, and you won't be surprised at all to hear, of course patients want to know why they're being recommended surgery, but they really want to know about those long-term things, how it will affect their quality of life, whether it really will deal with the underlying problem. So there's this mismatch. There's this mismatch with, on one hand, what surgeons say to patients, and on the other hand, what patients want to know. And we've been doing work to overcome this mismatch. And what we've been doing is developing what we're calling core information. Now, core information would be just the baseline. And for any operation, a surgeon would discuss with any patient considering that surgery as a minimum the core information. And core information would contain fewer than 10 things, but those 10 things, importantly, would be selected by surgeons and also by patients. So, for example, I'm a cancer surgeon, and what we found is that patients who have cancer surgery, they want to be told whether the surgery really will cure the cancer. And surgeons want to tell them that what might go wrong and whether it might need a second operation to sort out the problem. These things aren't generally talked about always. And so in the future, if any of you were to have an operation, what I would expect if this becomes standard is for your surgeon, for her to say to you, or maybe him, to say to you, discuss with you the core information things. And what this would do is it would give you enough understanding, just enough understanding to be able to, if you choose, to look before you leap. It may allow you to deliberate. It may act as a catalyst for you to ask more questions. It may mean that you really understand and you can sign the consent form, or it may mean that you can say no to surgery. So what we need now is core information sets for all operations. We need them for hip replacement and for heart valve replacement. We need them for breast and bowel cancer surgery. We also need core information sets for non-surgical alternatives. And we need to train surgeons to disclose the information, to have those conversations about the long-term results of surgery. See, because as we seek to improve our technical capabilities, it's equally important that we improve decision-making. Because all the technical skill in the world is not of any value unless we make the right decisions. And making the right decisions involves understanding what matters to patients, understanding what matters to surgeons, using the information together to make the right choice for that individual, which may be saying no to surgery. Thank you.